Hi, you're listening to the Psychopharmacology Institute podcast. I'm your host, Dr. Wegdan Rashad, and this is a show that aims to help you, the mental health clinician, stay sharp on psychopharm. Should you start a hypnotic with an antidepressant in a patient with suicidal depression? There's been some evidence that suggests that insomnia treatment may reduce suicidal ideations in patients with depression. But before we add more medications to the prescription, we thought to look into the evidence base for this. This episode features Dr. Jim Phelps reviewing the paper entitled Reducing Suicidal Ideation Through Insomnia Treatment, a Randomized Clinical Trial. This paper was published in 2019 in the American Journal of Psychiatry. Take it away, Jim.
Let's look at a trial of zolpidem for insomnia in patients with suicidal depression. The idea here is, if you're starting an antidepressant in a patient with insomnia, should you also start a hypnotic? And if you do, can you reduce suicidal ideation more quickly? The authors recruited 1,300 candidates with severe depression in this multicenter study. And after a structured interview to exclude patients with bipolar, schizophrenia, substance use problems, and after a sleep study to rule out sleep apnea, and then thorough informed consent, they were down to 100 subjects because everyone in this study has suicidal ideation. Everyone was started on an SRI, mostly fluoxetine, and then half also received zolpidem, while the other half received a placebo, all in addition to their antidepressant. Insomnia improved more with zolpidem than with a placebo, but the target in this study was suicidal ideation. They measured this by self-report with a scale for suicidal ideation, and also by observer, the Columbia Suicide Severity Rating Scale, in which patients are asked detailed questions about their thoughts regarding suicide. The difference between these two measures matters because, by self-report, zolpidem had no impact on suicidal ideation. But by the Columbia Suicide Severity Rating Scale, there was a slightly greater, statistically significant reduction in suicidal ideation compared to placebo. Interestingly, a whole bunch of secondary measures were also examined: hopelessness, quality of life, dysfunctional attitudes toward sleep, and nightmares. And for none of these was there a difference between zolpidem and placebo added to an SRI. So overall, it looks like this study was initiated with high hopes, and none of them really panned out, with the exception of a slight statistical advantage in terms of suicidal ideation reduction on one scale, the more objective scale. But there were some interesting side discoveries. Clinically, I was impressed by what happened when they stopped the zolpidem, which was done with no taper. For the next 2 weeks, they followed up by phone and found no worsening of sleep or suicidal ideation in either group. The placebo group or the zolpidem group both had those pills stopped abruptly, and then they followed them for 2 weeks. The zolpidem dose was 6.25 milligrams to start, but 75% of the subjects were increased to the 12.5 milligram CR dose. The insomnia index was actually improving during follow-up despite the discontinuation of the zolpidem, and more so for patients who'd received zolpidem than for those who'd received placebo, this further improvement. So very interesting and not suggestive that stopping it suddenly was leaving people with sleep problems. Also noteworthy was the simple fact of the study's existence in the first place. All of these patients had suicidal ideation. That was an inclusion criterion. Whereas, as the authors point out, usually patients with suicidal ideation are excluded. So based on their experience, no deaths or suicide attempts during this study, the authors conclude, quote, there are no reasons to systematically exclude suicidal outpatients from psychotropic randomized clinical trials, close quote. That's an important, forceful statement right there in the American Journal of Psychiatry. So one could conclude that this massive study was basically negative, that one of the main outcome measures showed no difference between zolpidem and placebo as add-ons to an antidepressant. Yes, insomnia improved more with zolpidem, but suicidal ideation did not in the main measure. The second measure did show a statistically significant edge for zolpidem, but the effect was small. The results wouldn't spur me to also add zolpidem when starting an SRI, although the authors point out that the effect of zolpidem on suicidal ideation was greater for those with severe insomnia. So certainly their data don't completely rule out this strategy. As the authors point out, CBTI, cognitive behavioral therapy for insomnia, is also an effective treatment that might be considered in this context. They chose zolpidem because they hoped for a much more rapid effect. But given the results, it's hard to argue for zolpidem over CBTI if you have a way to help your patients get CBTI. It'd be fascinating to see a replication using CBTI instead, but the massive scale of this multi-center study suggests that's unlikely. So in summary, adding zolpidem for patients with suicidal ideation and insomnia didn't really gain a lot relative to adding a placebo, except perhaps for some patients with severe insomnia.
So in summary, compared to placebo, adding zolpidem for patients with suicidal ideation and insomnia did not offer better outcomes. So, since you took the time to listen to this quick take, why don't you listen to the full audio and earn yourself some CME while you're at it? Click on the link in the transcript and become a premium member to earn your well-deserved Psych Nerd credits. If you're already a Premium or Premium Plus member and you refer a friend to join our platform, you'll receive a $50 Amazon gift card. You can also choose to join our newsletter to receive weekly updates delivered straight to your inbox. The following people participated in this episode: Dr. Flavio Guzman as general editor, Andy Rode as audio engineer, Pamela Gonzalez as the project manager, and myself, Dr. Wegdan Rashad, as the host. We'd also like to thank Dr. Jim Phelps for being with us. Thank you for joining us in today's podcast. Until the next episode, goodbye.